So my other hat that I wear for Medical College of Wisconsin is that I work at Children's Wisconsin, which is next door. So I have a clinic in our pediatric department where I see kids directly. I have no relevant financial disclosures for this talk. And it's important because when we're talking about these medications, every single one of them is branded. Now that we're talking about biologic medications, every single one is a brand name. I'm going to show you the alphabet soup that we deal with on a couple of these, but you won't know any of these meds if I don't use the brands. So we're going to talk about complex cases in pediatric uveitis and the lifelong complications that can come from undertreatment, review current treatment plans and biologics used in children and the limited data, and then discuss screening and referral guidelines. So we talked a little bit about this top tray of the uveitis toolbox. I'm going to show you my kid-friendly version of it now. In the kid-friendly version, we don't use difluprednate. It causes way too much steroid response, and even prednisolone makes me a little bit wary when other people aren't checking someone every 2 weeks on this medication. We use a lot of systemic steroids in kids, and then often we'll use sub-Q methotrexate. The pills do not work with kids. They can't take them. There's too many of them, and they're really hard on the stomach. We don't even touch mycophenolate because it's twice daily dosing. And we frequently use biologic agents in adalimumab or infliximab. Brand names are Humira and Remicade or Inflectra. So pediatric uveitis is scary. These are photos from my mentor, Dr. Goldstein. I want to just show you that the right eye here is not as bad as the left eye, but I don't like seeing this right eye, this patient's right eye either, so it's the one on the left on our screen. And we'll zoom in and I'll show you why. This right eye in this patient has posterior synechia, nearly 360. In kids, they can be very subtle. It's not that bright white. It's these fibrous bands that are developing that are very, very small. You can see them nearly 360 in this case. And then in the other eye, I'm going to show you something scary, and my goal by showing you this photo is to scare you. So this photo has 360 synechia. This is a slit beam showing you that there's also a Bombay-like appearance to the iris in this case. There's band keratopathy, nasally and temporarily, that I didn't show you on the other photo. And then if we go forward, this UBM shows you that vaulting of the iris, and it will actually reveal that that's a pseudophakic lens that's syneced down there. So we're headed towards cocooning that lens, and this eye is not doing well. So let's start talking about the bread and butter first, but I just want you to see those to be scared. This is a 3-year-old Caucasian female, separate case, not the same person, who developed left knee and right ankle pain at age 2, stopped walking. She's JIA diagnosis, and she's ANA positive from her rheumatologist. She's been given intra-articular steroids to treat an NSAID. That's a very common treatment pattern. They frequently won't start kids on those immunomodulatory medications unless they fail this multiple times. So I often see kids that have had like 7 intra-articular injections and that are just on chronic NSAID. They're referred for uveitis screening evaluation as part of the rheumatology protocol. This kid is central steady maintained in both eyes, normal pressures, no APD, full visual, full EONs. Slit lamp exam showed endothelial dusting in both sides, no band keratopathy, no KP. It's important when you first meet these kids to say whether or not those are present because it'll tell you if it develops. So you really need to look for the negatives on these kids. She's deep. She has 2+ cell, 2+ flare in both eyes. She has some posterior synechia from 2 to 8 in the left eye and also from 10 to 1030, so a couple areas of posterior synechia. I told you I don't like seeing that already. And then she's got pigment on the anterior capsule, which is very common in kids with JIA. I do want to point out that this is a slit lamp exam and this is a 3-year-old child. You can absolutely do a slit lamp exam on a 3-year-old child. They do not all need to go for EUA. If you start training them when they're younger, I have many patients that are 2 in my clinic that sit for their slit lamp exams. They do wonderful. You just have to start training them, and you see them monthly till they get the hang of it. You will get a better exam every single time in the clinic than you will with an EUA. There's one photo from my mentor of doing a slit lamp exam in the exam under anesthesia in the OR, where they have to actually lift the sleeping child up with the trach in their mouth to be able to do the exam. My department of anesthesia will never allow me to do that. So I will tell you that that photo exists, and I will tell you that your anesthesia department will probably tell you no if you ask to do it. So you've got to get them to be able to do this in the exam room. Dilated exam was reassuring. So this is the classic. This is JIA-associated anterior uveitis. She just had some 2+ cell. She has posterior synechia. She's ANA positive. What do we do? For JIA-associated uveitis, it's a non-granulomatous anterior uveitis. Risk factors are oligoarthritis, so the fewer joints that are involved, the more likely they are to have uveitis. Female, ANA positive, age of onset less than 4 years old. Complications include amblyopia, band keratopathy, posterior synechiae, cataract, glaucoma, hypotony, macular edema, macular atrophy, epiretinal membrane disc edema. It goes on. These kids lose vision, and we need to plan and address things now when they're young, so that when they're older, they can be sitting in this room and be ophthalmologists themselves if they want to, which a lot of these kids want to be when they grow up. So refer them for evaluation with pediatric rheumatology early, and then workup can be relatively short in these cases where JIA is clear, CPC, CMP, ANA, rheumatoid factor, B27. You should all have this if you see children in your department hanging on the wall. This is the screening guidelines. I'm not going to go through line by line and tell you. AAO has this published on iWiki. You can just grab this chart and print it. It's very easy to carry around. It just tells you who's high risk based on their age, what their ANA test is, whether they're less than 6, greater than 6, and how long they've had their disease. And then it tells you how often you should screen these patients. So you should follow this. It's a good guidelines based off of a good group of data. So what is the treatment for JIA-associated uveitis? We do it in conjunction with pediatric rheumatology always. You will not find a uveitis specialist that's treating kids by themselves. The goal is steroid-sparing therapy with reduction in sight-limiting complications. We do early induction of immunomodulatory therapy to prevent these complications that they see well long-term, and the standard stepwise treatment is going to be topical steroids followed by oral steroids. And then an antimetabolite, it's typically methotrexate. I really don't see azathioprine used very much anymore. And then a biologic, typically a TNF-alpha inhibitor. So let's talk about methotrexate. Methotrexate's an antimetabolite. It blocks dihydrofolate reductase. It's dosed usually subcutaneous in children and between 7.5 milligram to 25 milligram every week. It's given with folate to reduce side effects, and there are many: fatigue, headache, and then in the cases that I don't like, and I will switch this med if my patients have hair loss, for example, or GI upset, because those are intolerable and get worse as we go. We use subcutaneous because kids just don't tolerate the oral version. These pills come in 2.5 milligram pills, so if you're telling a kid that they have to take 10 milligrams, they're taking 4 pills every week, and these pills aren't too big, but they're also not too small, so tough for kids. It's a really good starting point when kids have mild anterior uveitis and none of those complications we're talking about. So that case that I'm showing you with posterior synechiae doesn't fit great for using methotrexate because she already has posterior synechiae, right? So it's really good by itself. If you just have a little bit of cell, let's say it's your routine screening, you've got a 5-year-old, they've got half plus cell, I would think about asking rheumatology for this medicine. We recommend escalation with combination dosages of an antimetabolite like methotrexate with a biologic like a TNF-alpha inhibitor in any kid that has severe sight-threatening complications, and posterior synechiae are one of those. Band keratopathy, the other things we were talking about. Adalimumab. Adalimumab is a biologic. The originator version is called Humira. I'm sure many of you have seen commercials for that. It's the only approved biologic for non-infectious intermediate posterior and uveitis. It's also FDA approved for JIA ages 2 and up. Success can be achieved with variable doses, and it's based on weight. So we use 10 milligrams for very small kids, 20 milligrams for people in the middle, and then 40 milligrams for adults. And for kids that are 8 to 10 usually, that's when they usually hit about 30 kilogram. It's dosed every 2 weeks. If we have refractory cases, we can go up to every week dosing of adalimumab. Adalimumab is an injection at home. I should say that for this so that you guys know about that. So this is an at-home pen. It looks like EpiPen. Infliximab is also a biologic, but it's an infusion. Okay, so you have to go into the hospital or an infusion center to get this. In pediatric rheumatology in our department, they go into the infusion center in our hospital. The originator is called Remicade. 70 to 80% of children who received this medication had remission with doses between 5 milligram per kilogram every 4 weeks or 10 milligram per kilogram every 4 weeks. So between 5 and 10 is a typical dose every 4 weeks. That's very high dose compared to what rheumatology uses. They will frequently use 5 milligram per kilogram every 8 weeks, so half the dose that I'm recommending. It's actually double half, so 4 times lower dose if I'm talking about starting someone on 10, and they start getting very skittish about using those higher doses unless you're working with someone who's used to doing it. So if you're working with a rheumatologist who's not used to working with uveitis, the first thing you do is you send them papers that I've linked here about using these higher dose medications. So the consensus starting dose for kids when they've got problems is 10 mg per kg every 4 weeks, and this can be escalated all the way up to 20 mg per kg every 4 weeks. I really want to caution you, there are biosimilar medications coming out everywhere in medicine right now. They're not equal to the originator medicine unless they've been tested. Typically, approval for biologic medications to be a biosimilar means that they've met one indication in testing as the originator. With uveitis being very severe with higher doses, we don't necessarily know that that's true. And I want to point out that when we tested this, a group out of Cleveland Clinic checked for the biosimilar infliximab ABDA. They showed that it did not seem as efficacious as the originator in treating uveitis. So we don't know if that's dose dependent or if there's a slight change, but we know that that medication by infusion does not work as well as Remicade. We have very limited data on the other ones. A lot of people are being switched to these biosimilars, so infliximab DYYB is out now. I have many patients on it, and the good news is it does seem to be efficacious like the originator for uveitis. We have a pending publication, Dr. Goldstein, Dr. Zage, and I, and another doctor, Dr. Morthy, about this. New one that just hit the market a couple months ago is adalimumab ATTO. It's the first biosimilar to Humira. We have zero data. There's a couple papers from Egypt that says that it doesn't work at all. So we have no idea. So case one wrap up, we have a classic presentation of JIA with associated chronic anterior uveitis. She does have evidence of sight-threatening complication in posterior synechiae. We treated initially with topical steroid and oral prednisone. She was rapidly transitioned to methotrexate subcutaneous 7.5 milligram weekly, plus the adalimumab 10 every 2 weeks that I was talking about. She failed taper, so once we're on those medications, we try and taper the steroids. She failed the taper off the prednisolone, so we had to escalate her to the 20 milligram of adalimumab, which we did instead of going to weekly Humira at 10 milligram, and now she's controlled at 2 months. Case 2. 3-year-old Caucasian male born in Wisconsin. At age 2.5, he developed left knee swelling and was treated with intra-articular steroid plus NSAID. Like I said, this is very common in this clinic that I run. Workup was ANA positive. At age 3, he saw pediatric ophthalmology, found 2+ cell. He was started on prednisolone 4 times a day in both eyes. At 1 month follow-up from that, his pressure was 40 and 40. So we know that steroid response starts 2 weeks after you start the medication, so you should see the patient, especially these very young kids, 2 weeks after you start the medication just to check. So I didn't like that this was 4-week follow-up, so just as a plug here, if you are starting a child on steroid, see them every 2 weeks. You don't know when it's gonna happen, and it's going to happen. It's a matter of when, not if. Patient was started then on dorzolamide timolol twice daily, tapered prednisolone to twice daily. I got a phone call and they referred them over to me saying, please help. On exam with me, so this was on that dorzolamide timolol already, the pressure came down wonderfully to 14 and 19. Vision is still doing well. This is a 3-year-old who's able to do Leah blocked letters. That's really good for him. He also had that 2+ cell. This is a very common amount in this population to see, so about 2+ cell is where I expect someone with JIA who's untreated to be. It doesn't usually get too much higher, it doesn't really go too much lower by itself, so it's about 2+. And then does have a little bit in that anterior vitreous at about 0.5+. Nothing posteriorly though, and I checked that very carefully because I saw the anterior vitreous cell. So this is a classic case of JIA-associated anterior uveitis with steroid response, and they're ANA positive. What do you think we should do? Well, I told you steroid response is one of those scary things, so I want this child eventually on both an antimetabolite and a biologic medication. So, sight-threatening complication. He's too dangerous to escalate topical prednisolone, so often I will decrease it and then start an oral medication. So I start the oral prednisone to get him over to when we get these medications approved, because it takes insurance companies about 1 to 3 months to get these medicines approved. And then I did a panic phone call myself over to our pediatric rheumatologist saying, can you please start methotrexate today, because methotrexate takes 3 months to start working, and can we get this adalimumab through the fastest process you've ever done it before for this child? I saw him 2 weeks later because of the history of steroid response, so I want you to see that you gotta see him close if you got him on steroids. And he actually had gone through this really, really fast process and he got his adalimumab, but it's the ATTO that we have no data on. And you need to stand up for your patients. Rheumatologists had no idea, and frequently, depending on your state, the pharmacy does not have to alert you as the physician that they are interchanging one of your medications for a biosimilar. So I want you to just be very aware what your state's laws are. In some places they have to alert you, in some places they have to ask you, but these laws already exist, and in my state they are able to do it without telling me. So without my knowledge, he was on ATTO. Good news though, cell is coming down, he's at 1 to 2+. In both eyes, pressures are doing okay. I wrote a really long letter to them telling them that there's no data about this. I cited the study in Egypt that wasn't doing well, and it was denied. So 2 months later, as a positive, before that methotrexate's really working, child's quiet. He's on the ATTO, he's on methotrexate, he's off all of his drops. So is this an indication that ATTO is working? I hope so. I really, really hope so. I wish we weren't trying it in a 3-year-old. Next case is an 8-year-old black male born in Wisconsin, 2 weeks of light sensitivity, had COVID-19 3 months ago, and then was referred to Pediatric Ophthalmology for atypical corneal endothelial opacities from an outside ophthalmologist. I wanted to show you this photo, and I did the zoom out and the zoom in so that you can see this. This is with a cell phone at the slit lamp. You all have a cell phone in your pocket. You can all take photos at a slit lamp. You just put the camera down the little pipe on this one ocular, and you can take great photos. So I was able to see this patient before I could see this patient, right? Really cool, interesting type of KP here. They kind of look like cobblestones in that inferior angle. I don't know if you can see that kind of square angled pattern that they have. And that's atypical KP, right? They're cobblestoning, they're large, they're at least mutton fat. So what's going on here? They started patient on prednisolone, and what do we do for our workup? Workup in kids when you don't know what's going on, when it's not clearly JIA, should be big. You want to get blood once, you don't want to get it multiple times, so we get it big, okay? CBC, CMP, ESR, and CRP to tell us if we're doing better if we get blood again. That's what the ESR and CRP for. We're not looking for GCA. Angiotensin converting enzyme, I want to note that depending on where you're working, at the hospital that I work at, because it's children's, it's scaled correctly, but that needs to be scaled for children because the pediatric ACE level is different than the adult ACE level. Lysozyme and chest x-ray, if the kid's old enough, you don't do a CT scan in a child. You can check your RPR. I frequently won't check the specific testing in children just because I have a little bit lower likelihood unless I'm very concerned. Quantiferin, ANA, rheumatoid factor. Urine beta-2 microglobulin checks for tubulointerstitial nephritis and uveitis tenu, which is a big diagnosis that we're seeing in more populations than we expected before. A lot of papers, hot topic in uveitis. And then your institution-preferred testing for viral kind of etiologies. This can be from the blood, either by PCR or through EIA testing with IgG and IgM. This kid's entire workup is negative. So they come to my clinic 1 week after on prednisolone 4 times a day. Pressure is 29. Again, it only took 2 weeks for that pressure to go up in this eye. What's going on? They're still 20/20. Slit lamp exam shows still persistent but improving 12 granulomatous KP that are in Arlt's triangle, so I'm not thinking viral because they're low. 2+ cell in the right eye, 3+ cell in the left eye. They don't have posterior synechiae, but they do have Kappi nodules. There's rare AC cell in the solid vit of the right eye and the left eye. And then dilated exam, because we saw some cell, is normal. So what do? We make our list. This is a granulomatous anterior uveitis. There's keratotic precipitates in both eyes. There's a steroid response in the right eye. What are we dealing with? All of our blood work is negative. Well, what if we missed something, right? What if the blood work is wrong? I thought maybe this is sarcoid, maybe this is tenu still. Based off the way these KP look, they're granulomatous, they're a little irregular. This is a child. For tenu, you can check something called HLA-DRB1, and if it's positive for 0102 subtype, it is high likelihood for it to be tenu. So this child ends up being positive for that as we go forward managing his steroid response. So we go back and forth for a number of times using prednisolone, starting medications, and ends up being this DRB1 positive. So now this child's a tenu suspect. We have to get nephrology involved because tenu, the devastating thing about it, especially in a young child, is that it can affect their kidneys. Nephrology's on board and we start treatment. So over the coming 2 months, we go back and forth with the inflammation. We're using steroid, we're encountering IOP elevation, we're going up and down on our medications. We're able to start the adalimumab plus methotrexate that this child needs because he's got some severe qualities to his type of uveitis. Even though it's not the JIA, we use the same rules in a child with uveitis. By 3 months, we're able to wean him off the oral prednisone and put him on lower doses of prednisolone, and then by month 4, we were just able to start lowering his IOP suppressants, and he's maintained 20/20 vision in each eye. I don't know that we would have encountered that same outcome if we weren't so aggressive with the IMT from the beginning. So in summary, what I want you all to remember as we're thinking about taking care of kids with uveitis is screen all kids with JIA according to the guidelines. Print them out if you're seeing kids, put this chart in your office. You really need to follow it. You can make a dot phrase if you use a system like Epic that has all of the screening guidelines in it, then you don't have to look at the chart and you just delete everything that's not related to your patient. That's how we do it in my clinic. You can refer early any patient who has sight-threatening complications developing. So if they're getting band keratopathy, if they're getting posterior synechiae, if they're getting steroid response, refer those to a uveitis specialist. They're really, really red flags, and that's how you're going to encounter that case that we were talking about for the other kid. And then for pediatric rheumatologists, know that they're your best friends. They are going through a lot of these prior authorizations for you or with you, and prior authorizations are not your best friend. Our goal for every kid is to keep them 20/20 so that they can be an ophthalmologist if they want to. If they want to be a fighter pilot, they can be a fighter pilot, the things that you need to be 20/24. So start medications early in these practice. And thank you for listening.